The Quan implant restoration method allows the fabrication and insertion of a one-piece implant prosthesis in one single step after implantation.
Today, I will go over a Edentulous maxilla case with dental implants. Hi, my name is Norman Quan. I'm a general dentist. I've been practicing implant and restoration since 1985. And I want to share some of my experience with you. So today I'm going to discuss the restoration of the Edentulous maxilla with dental implant. This is probably one of the most difficult cases that one would encounter because there's a lot of requirements like stability, aesthetics, function, and that in conjunction with the limited the quantity and the quality of bone in the maxilla. So what I'm showing you is the concept that I have been start using since 1995. The prosthesis is a one-piece crown and bridge type. It's a metallic with porcelain, screw retained, and the most important one is the engaging restoration. Without that engagement, that the prosthetic complication going to be very frequent and sometimes catastrophic. So I'm going to run through the case with you. First of all, the implant we use is a standard Bronnemark implant with an external hex. But instead of using it by itself, what we have done is that we have designed and manufactured an index healing abutment. And in addition, we put it prior to surgery, implant placement, we have pre-connected, pre-assembled that index healing abutment to that Bronnemark implant, a screw implant. As such, you can see, okay, this is a hex abutment, which is screwed into the standard Bronnemark implant. So now keep in mind, this is 1996. At that time, I religiously believe in using the surgical guide, surgical planning, which I found it sort of useless after I've done in many cases. And so nowadays, when I see people using this surgical guide with digital produce, using the CBCT scan, those things I have found it very not necessary. Later on, I will explain why this is the case. So, nevertheless, 1996, I believe in the surgical guide, the importance of it. So I make this a clear surgical stand, and with even more finer positioning of the implant itself, and try to place it as you can see it. So in addition, at that time, I found it as more useful to use the abutment where everybody can see as a surgical position. So instead of telling them what the position of the implant is, I was trying to tell people that use the abutment that is obvious. So if you know the position of the abutment, the implant position will follow. That is the concept. So as you can see, once we have the full thickness flap open under local anesthesia, we put in the surgical guide and that try to precisely place the implant as was planted in the treatment planning model. So this is the central incisor. This is the left central incisor, and I'm about to put the cuspid position here. And on the right side of your screen, or left side of your screen, that will be the left cuspid, or we call it number 7, number 6, or 1-3, we call it in Canada. So after the precise placement of the abutment, okay, so instead of saying the implant, at that time I was thinking, gee, abutment position is really where the prosthesis is going to be linking to. So it's more important to talk about the abutment position instead of the implant position, which nobody can see. Okay, so we situate and leave the healing abutment in place as a single stage healing, because we have prior to this concept, we have done testing to at that time to prove there's no difference in terms of survival rate in terms of submerged healing versus the this kind of non-submerged healing. Basically, just leaving the healing abutment there and let it heal around it. So after a couple of weeks of healing, you can see the attached gingiva form a very tight adhesion to the titanium healing abutment. So before prosthetic procedure, we have to actually have a spacer, or we call it a healing ball, meaning just basically make the soft tissue peel away from the healing abutment, okay, to allow us to manipulate or to start the prosthetic process. So this healing abutment is indexed as well, meaning matching the index healing abutment, and that the top of the healing ball has a provision for a screw, so it can put it there to keep the tissue apart. Usually after 1 week, the tissue will be opened up quite nicely. So after 1 week, we remove the healing ball, and then we reattach what we call is a transfer coping. But it's essentially the same healing ball as we used previously to open up the tissue. We call that to profile the soft tissue. But in this case, we use a long healing ball. So to allow the impression material to flow underneath the bridges of between the healing ball, and then help to lift up all the healing ball in one step. So all the timing of each axis are maintained, which is a very important point. As we go along, further along, we will go into more about the advantage of the axis, the timing of it, the engagement of it, and the stability, or what we call it, the retention, and also the resistance of this specifically indexed healing abutment, which is very useful. So after we remove the wash impression with basically polyvinyl siloxane material, and you can see the index part of the healing transfer coping with this axis maintained, and the timing of each in en masse, so to speak, or the timing of each and every one of them are related in a specific manner. And this is a very important point. So after removal of the healing abutment of the healing ball, you can see the healing abutment in place, and the soft tissue or the attached gingiva basically is very important in terms of the long-term survival, which I will explain again later on in different sessions. So we have 8 healing ball, the 1-1 and the 2-1 incisor, and the left cuspid and the right cuspid, and also posterior support. Okay, so basically this is what now we call it a tissue level type of a restoration, because we do not need to remove the healing abutment now. So in other words, we can leave how you call this a healing abutment or final abutment, it's just a term. But the fact remains, you don't really need to remove that healing abutment to get to or change it to a different abutment. to support your final restoration. So again, with that, we have invented a way how to telescope each healing abutment and engage each healing abutment as well, and that just screw retain with the 4 screws here in the posterior part, because putting screw in the interior would create aesthetic problems. So we just basically retain the whole framework with 4 screws, and then this framework, then we can put porcelain on it. And then this is the final prosthesis inserted into the 8 implant for the edentulous maxilla. Okay, and this is how it goes. In the beginning, we were using different type of material, not porcelain yet. We were using some acrylic type, or we specifically call isocyt material, which have its own problem over time. And nevertheless, in 1996, we were basically start this type of restoration with the same healing abutment, index healing abutment, is the same restorative protocol with the same type of restoration, and continue that for the next 25 years until today. We have not changed any of the protocol nor the material, except for the porcelain part of it. So this is the final X-ray that forget about the lower one, because they are just the regular high water type of a Browner mark for the lower, but in the maxilla, because of the function requirement, like aesthetics, phonetics, and aesthetics, phonetics, and function. So we have to create this one-piece screw retained porcelain bonded to metal engaging type of a restoration, which we will continue to clinically validate for the next 25 years. And so all the cases that you will see will be of similar type of restoration. So the next one, what I will do is to show you exactly the same case, but after 10 years in function. And this prosthesis for this patient happened to a permanent one, meaning a lifetime. And she passes away maybe about 13 years after the prosthesis was fabricated. Thank you very much for watching. If you have any questions, comments, or cases, please comment below or email me.